But let me introduce to you this afternoon a partner in the healthcare practice group of the law firm of King & Spalding. He's a recipient of a bachelor's degree in business administration and finance from the University of Texas, Austin, and a JD degree from the University of Houston Law School, where in 1995 he was a magna cum laude graduate. His primary areas of practice involve representation of hospitals and other providers relating to healthcare regulatory matters and payment disputes. His representation includes litigation before administrative law judges and appeals panels, such as the Medicare Provider Reimbursement Review Board, the Medicare Departmental Appeals Board, the Texas State Office of Administrative Law hearings, and federal courts. Mr. Etzel is was listed as one of 14 outstanding healthcare litigators by Nightingale's Healthcare News in 2008 and 2009, and was previously named as one of the outstanding young healthcare lawyers by Nightingale Healthcare as well. The publication highlighted his work in the areas as lead attorney in many federal court decisions, favorably reversing an overly restrictive Medicare payment policy. In addition to his honor, Mr. Etzel was named to the Best Lawyers in America in 2008 to 2010, and listed as a Texas super lawyer in healthcare law and politics, and the publishers of the Texas Monthly in 2010 identified him as a Texas rising star. My pleasure to welcome and to ask you to join me in welcoming from Houston, Texas, Mr. Greg Etzel. Greg?
Thanks, Gary. Well, like Mr. Weber, I wish my mother were here to hear that as well. And like Mr. Weber, it's very difficult being put in this position to follow his outstanding job and then be right before the reception, because if there's one other rule that you learn in speaking, that is everybody's ready to go to the reception. So I promise I will not go over, and I'm going to pull out my clock right now to make sure. Today I wanted to talk a little bit about what we've labeled as megatrends in the healthcare delivery and finance system. Those drivers, as Jerry mentioned, kind of where the money is, what's going to potentially drive healthcare delivery in the future. And while it's difficult to predict with any precision what healthcare delivery and reimbursement will look like 5-10 years down the road, predicting the direction of change is significantly easier, particularly given what we've known. And I think you've all heard pretty much the key factors that are the backdrop to this story of healthcare delivery change. The healthcare spending in this country is now almost 18% of our gross domestic product. That was from 2010. That has nearly doubled since 1980. So in 30 years, we've seen a substantial growth in the amount of healthcare spending in this country. Pair that with the fact that nearly half of that spending comes from government payers at the federal, state, or local level, and the deficits that we have, and you see that there is an emerging problem and crisis in our delivery system. On top of that, as Mr. Weber and quoted Mr. Obama, President Obama, we're not really getting what we pay for in the healthcare industry. Despite spending substantially more than many of our country's fellows in Europe, the outcome and the results are substantially less favorable. And so with that, we will kind of discuss a number of topics here that we've labeled as megatrends. And I'll kind of go over these briefly and then kind of hit on each of them more. But also what I want to do is kind of encourage discussion. If there's anyone that has any thoughts or reactions with respect to your experiences in the healthcare field, because this is very much a process of trying to figure out the direction that this large moving ship is going in U.S. healthcare delivery. I think we will see a shift that's happened in the late 2010 2000s, right around 2010, to see a larger shift toward focus on outcomes rather than inputs. The definition of what is a unit of service is going to be something that will be expanded from what we're used to seeing on kind of a pay per visit, pay per service provided. That's going to grow, and we'll talk a little bit more about that. Both providers and beneficiaries, for example, will be bearing more risk, more costs themselves. Quality metrics, something that again started in the mid-2000s that became part of the Affordable Care Act. The link between quality and reimbursement at the Medicare and Medicaid levels, and of course, following at the commercial market level. Coverage restrictions, a shift toward more evidence-based medicine will also be part of what we see coming down the pipe. Rationalizing payment rates among different providers of similar services. There's a lot of discussion in the MedPAC report to Congress, in the most recent March MedPAC report to Congress, with respect to paying for services at the most efficient level of delivery. If something can be provided in one setting at a lower cost, there's no reason for a payor, Medicare, for example, to pay at a higher cost in a different setting. And so I think we're going to see a lot of emphasis on that. We'll talk a little bit more about that. Expanding the percentage of the populace covered. Of course, this is one of the main focuses of the Affordable Care Act, and obviously an item of substantial controversy, and we can talk a little bit about that as well. Reliance on the market for driving price and quality. I do think we will see, as Mr. Weber pointed out, a shift toward more patient liability as employers play a greater role in developing kind of the new wave of outcomes-based delivery of medicine. The focus on the chronically ill population. Of course, this is an easy area to target in government spending areas because it's one of the largest. A substantial amount of Medicare and Medicaid spending goes to chronically ill patient populations. Reductions in the increase in payment. Obviously, we're already seeing this in Congress with respect to provider payment rates, and that will just continue to be something that providers have to get used to. Another focus that's really kind of puts providers and suppliers of services in the squeeze game is, as the payment rates are going down, the enforcement mechanisms and the abilities of the Department of Justice, the Medicare agency, to data mine and be more precise in targeting potential overpayments creates another squeeze for providers. And then finally, a rationalization of the end-of-life care. As you all know, that's a substantial part of the healthcare spending in this country. And when those costs are compared to other countries, it is dramatically higher. It's one area that is quite a political hot potato. Okay, so first, let's talk a little bit about payment for outcomes. And really here, we kind of want to think back historically as to the way the Medicare program paid for services, medical services. Traditionally, it was all cost-based. And of course, in 1983, it shifted to a prospective payment system that was still based on cost, but more of an average cost-based reimbursement system. And throughout that, the level of service, or the unit of service, was always defined in a kind of discrete manner with respect to a particular hospital discharge for a particular diagnosis, or a particular physician service, a skilled nursing facility, day of care. All were the services were very unit-driven, very specific. What we're seeing now with the CMS Centers for Innovation and some of the demonstration projects is a shift moving toward more outcomes-based payments. And through that, a great expansion of the term episodes of care will be kind of a new catchphrase in the coming Medicare reimbursement era, I believe. Already we're seeing a bundled payment initiative that is encouraging providers to define their own episodes of care and create a package of services that will be reimbursed at a rate that it's going to be proposed by the providers, but that ultimately CMS, the Medicare agency, will agree to. And it's a way of trying to reduce the costs of that package of care. For example, let me give you an example of what one of the package services would be under the bundled payment initiative. For a hospital type stay, it would include the 3 days prior to the admission and then a window of 30 days after the admission, and it would include all the services within that window, not just the hospital services, but all services provided. And this is a fundamental change, obviously, from the manner in which services are reimbursed at this time, in which a hospital gets a discrete payment per discharge, physicians or other suppliers get their individual payments, the rehab hospital, the skilled nursing facility all get different reimbursements. This fundamentally would change it and provide essentially a single bucket of payment that would then have to be meted out by whoever was in charge of that particular, administering that particular program. Sometimes that can be, typically it's the hospital, but there are physician organizations and others that are kind of taking that role. As Mr. Weber talked about, managed care, ACOs, medical home models are again another aspect to balloon the unit of service even further, to talk about patient lives, payments for patient lives, and to have more direct emphasis on the provision of care to individual beneficiaries and focus on maintaining health rather than paying for the acute care episodes. Now, what this implies when you start to expand the service bundle is that the risks are going to shift to the providers more. It becomes incumbent upon the providers to manage the costs or risk losing money in the transaction. This will require, obviously, substantial capital. You have to be large enough to kind of play the game and be able to take on that risk in order to do that. You also have to be nimble in being able to contract and manage your providers within your group, whether it be an ACO or if you're in a bundled payment kind of situation where there's other providers. But you've got to be nimble enough to control the costs of other providers as well and be able to react to the types of patient populations that you're getting. It will take be a need for very robust information gathering systems, internal or externally acquired actuarial information is going to be important for these types of organizations because they're going to be assuming the traditional risks that insurance companies would normally be taking. Obviously, one of the kind of negative factors to this approach, and one that will be constantly monitored and scrutinized, will be making sure that all patient populations are covered, because there is an incentive in this type of payment model for providers to focus on patient populations where the costs are lower, to try to maintain kind of that competitive edge of getting a higher margin on their bundled payment. So there will be some need to carefully structure these, and that's part of what's going on with this bundled payment initiative. The Affordable Care Act requires the CMS, the Medicare agency, to adopt demonstration projects as of January 2013 to put these bundled payment initiatives into practice in various areas to see how it is going to modify the reimbursement for providers. Now, measuring quality, quality-based and value-based purchasing has been the real buzzword for a number of years now. Started back in the Bush administration with a shift toward quality metrics. Really, the genesis of the whole shift toward the measurement of quality and payment for quality came with the Institute of Medicine report in 1999, I believe, that identified that 100,000 people a year were dying of hospital-acquired infections or preventable illnesses. And part of that was a congressional reaction in 2003 to require CMS to begin collecting quality data from hospitals on a number of measures. It started as just 10 measures, and they were basically process-driven measures, very simple things like providing aspirin upon admission for heart attack patients. But it quickly expanded both the number of measures and the payment incentive for reporting those measures. If you did not report those measures, you did not receive a 2% payment increase. Well, that was kind of the dawn of this value-based purchase program that started in the Bush administration and really became law in the Affordable Care Act, in which those quality measures will now not just be reported, but will be used to plug into a specific formula, how you perform versus those measures, and an amount of your reimbursement will be paid directly based on how you perform vis-a-vis your peers. So if you are hitting in the upper echelons of a particular quality measure, you will be entitled to receive a payment increase vis-a-vis your peers for that particular service. And really what happens is it's kind of a global payment that begins as only 1% in 2014, but will be increased to 2% over the next 4 years. And I do think what we'll see here as Congress, if Congress can agree on anything, I guess that remains a mystery, but I do think if history is any indication that we'll see the amount of the pool that is held back for value-based purchasing incentive payments to increase from the 2% margin to a larger percentage. CMS, I think I've heard, informally discussing they want nearly half of the DRG, what's now the payment for hospital services, to be value-based driven. And that's a substantial amount, and really I think can drive the dollars in healthcare to higher quality performing providers. And it's important to kind of follow what's going on with the hospital value-based purchasing program because it's more mature, but the Affordable Care Act really requires that this type of program be pushed forth to other providers and suppliers as well, both in the skilled nursing facility, physicians, others are going to have quality metrics being measured and payment derived from those measures. There are transparency and accountability kind of go hand in hand with this value-based purchasing program. There's hospital compare and physician compare websites that are out there that allow the consumer to directly go look at providers of services in their area and determine how they have performed on a number of quality metrics. And it's the idea is to allow the consumer to have that information to drive healthcare choices to quality providers. In addition, there are patient surveys that hospitals fill out that will be part of their value-based purchase score. Again, the ultimate reimbursement is based on how you perform vis-a-vis certain metrics. These metrics are an important part, obviously, of that formula. And so designing the metrics is a key factor, and it's important to try to be at the table when it comes to being part of the National Quality Forum and the design and development of what's going to be measured for purposes of these value-based purchasing programs. We've seen over the last number of years, and I think it's going to obviously continue to shift, and that is a shift from more process-based measures. As I mentioned before, there was the aspirin on admission, certain antibiotics pre and post surgery for surgery patients, to now more outcome-based measures. How did you do with respect to your hospital-acquired infections, various categories of those infections? What was your readmission rate within 30 days? Your patient who died within 30 days or 60 days of discharge. All of those being factored in to measure how your outcomes were vis-a-vis others, and that's how payments will be driven. The bottom line question there, how do you deal with lower quality providers? I think what's going to ultimately happen is they'll effectively be driven out of the marketplace as more and more reimbursement shifts to larger and larger to more portions where a value-based incentive payment is driving the payment, those providers that are providing quality services are going to be able to have a better market position. They'll get more reimbursement than those with lower quality who may not be able to recover their costs, kind of forcing everyone up the ladder, so to speak, in the quality metric. And that's the idea behind the plan. Now, there are some issues with it, and I won't go into much detail here, but some of the quality measures that are initially part of the hospital value-based program are very tightly squeezed together, so that in some measures, if you are compliant with a particular quality measure, let's say aspirin on admission 98% of the time, well, you may be in the lower 25th percentile of all hospitals in the country, just because the mean is way up at the 99th percentile. So there's kind of a compression factor that I think is part of this problem, part of the program right now. And as other providers get linked into value-based purchasing program, those are the types of issues that they will need to address with the policymakers. Coverage of services. Again, here, I think we're seeing a shift again toward more national coverage determinations. When we talk about healthcare being at a community level, that's always been the standard as practice of what was medically necessary being driven at the local level by prevailing medical standards. I think we're seeing CMS shift to a model of more and more evidence-based medicine, publishing greater numbers of national coverage determinations. This is seen by some as kind of a tendency toward the rationing of health care, but I think if we look at it, health care delivery has always been rationed in some extent by the medical necessity concept that is involved in the Medicare program or other private insurance contracts. But this has a tendency to shift things to a more federal standard, and that can be somewhat problematic. I think the positive is on the screen there, that they basically follow evidence-based medicine. It's doing what works, and so we kind of put that into play. The downside is it has a tendency to create more of a cookbook medicine, or this rationing concept. And you talk to a number of physicians about this, it can kind of rub them raw in some respects with respect to their ability to kind of follow the leading edge of medicine rather than practice on just kind of what's worked in the past consistently. And we see this a lot with respect to coverage decisions and some of the appeals that I work on with respect to payment denials for certain services that may be on the emerging end of medicine. And this is something that I think is something to watch, particularly giving the enforcement authorities that are out there for the Medicare program. When you have a recent example that we've been dealing with comes in the implantable cardiac defibrillator context, in which a number of physicians were implanting these devices based on current standards of medicine that were safe, effective, but it didn't fit with the national coverage determination that hadn't really kept up with the current trends in these devices. And what had happened was the Department of Justice came in and is accusing a number of these providers of submitting false claims by implanting these devices. And it really takes a simple coverage determination or coverage question and turns it into a potential act of fraud. And that's an area that I think is of substantial caution for all providers as we kind of move into an era of more federally based standard of medicine. Now, the MedPAC report the last two MedPAC reports have recommended, specifically with respect to evaluation and management services in the hospital and physician office settings, to equalize the payment there. As you may be aware, a E&M service, an evaluation and management service, at a hospital outpatient department gets paid significantly more, sometimes up to 80% more, than the same service in a physician clinic. And that is because of the higher costs incurred by hospital and things of that nature. MedPAC has questioned this concept and is really pushing Congress to enact a law that would equate the payment for these evaluation and management services, whether they be provided in a physician clinic or a hospital outpatient department. This, when looked at from a reimbursement policy perspective from the government side, this makes a lot of sense, and it's something that MedPAC is really pushing, not just in this particular instance with E&M or evaluation and management services, but beyond that as more of a concept in general, driving healthcare to the most efficient setting. If a service can be provided in a physician's office, then why are we paying for it in a hospital setting? And why are we paying more for that particular service? So by reducing the payment rates to the most efficient level of care, the goal is to drive patients to those areas and have the rates lowered. Now, this really is kind of a difficult issue for a number of hospitals who have, over the last several years, purchased physician practice and converted them into hospital outpatient departments and in order to obtain that additional reimbursement. And so this is something that I think is there's a political fight on the way here. But again, it goes beyond just hospitals. We're talking about ambulatory surgical centers. And what about post-acute care settings? As we talk about moving to bundled payment methodologies, things of that nature, we see kind of the lines start to blur between some of these post-acute care providers, LTACS, inpatient rehab facilities, skilled nursing facilities. All of these really kind of had their proliferation as the reimbursement scheme developed over time in Medicare. When the prospective payment system was adopted, a number of these facilities were excluded from that system, and so patients migrated after their discharge into a LTAC or a skilled nursing facility or a rehab facility, and a whole different payment for their services was generated and paid by the Medicare program. Once you have a bundled payment concept, some of the distinctions of this are less important. And I think the MedPAC discussion is along those lines in that, well, if we have a situation where we have post-acute care that's needed, we need to make payment at the most efficient level and rate. And there was a recent study I saw not too long ago that was really promoting home health agencies as the most efficient provider of services for a number of the services that are done in the skilled nursing facility and inpatient rehab facility setting. In addition, there's a little note there with respect to wage adjustments for hospital rates. There are a number of factors that go into determining what a hospital gets paid, and a number of hospitals have exceptions, regional exceptions for their labor share of this wage adjustment. Again, MedPAC is pushing and CMS is pushing to try to more equalize those payment rates. Expanding the portion of the population that is covered, and this is the hot topic the last few weeks at the Supreme Court, obviously. It may or may not be a constitutional right not to have health insurance, but the concept of individual responsibility is embraced by both parties. So if we step back from the angst and the rancor at the Supreme Court and on Capitol Hill, I think both parties recognize that what's necessary to improve the health care financing in this country is a concept of individual responsibility, shifting payment down at the patient level to the extent that it can be done. Whether or not the individual mandate is constitutional is something that I think is subject to question, and certainly I think a lot of legal practitioners are really questioning that after the oral argument. And really, one of the things that I thought was surprising that a number of us are questioning now is whether or not the entire act will be thrown out, based on some of the discussion that was gone on between the judges and the council there. I thought kind of the safe bet going in was the individual mandate was in substantial trouble. The Commerce Clause was probably not going to reach that far, but that the rest of the law would probably be safe and move forward. Well, after the oral argument, I think there's some of us that are kind of scratching our heads and wondering, well, what's going to happen? There was at least one comment by a justice saying, well, it would be more of an act of judicial activism to try to carve out things from this 1,200-page act than it would be just to throw the whole thing out. And so that is something that's going to be very interesting to watch, because a number of the reforms that we're talking about here today are all, and that be the topics of this weekend, are all part and parcel to the Affordable Care Act and its reform of the health care delivery system. What happens if it's thrown out and we have to go back from scratch? There are a number of issues in it, all of these quality issues, a lot of the payment reform issues that I think are non-controversial, that were really, some of this was sitting in congressional committees in drafts in the Bush administration. So I think there's a large portion of it that is non-controversial. The problem is getting action from Congress on something that big in time. So that could really throw a lot of things into chaos, particularly when you think about how much of the act has already been implemented. But the second portion there, the second bullet, talks about another thing that was really kind of a focus of the oral argument, and this expansion of coverage incrementally. Of course, you had the individual mandate, but you also had the Medicaid expansion. Expanding the Medicaid population was a substantial part of the act. I think the state's position on that was less strong than on the individual mandate, so I don't think the Medicaid expansion is going to be overthrown unless the whole act is thrown out. But it does provide a substantial burden for states once the clock ends on the full federal participation. But that's one avenue of expanding coverage through Medicaid expansion, and then you have the insurance exchanges that are going to be on the market in 2014 for patients to buy directly through these exchanges. And this will dramatically affect the competition in the market, and we may see a number of things happen if the exchanges go through. There may be, very well, a decrease in the coverage of employees by their employers. As employers, you can pay a penalty under the Act, but that penalty is generally substantially less than insuring your entire workforce. So that may be an issue. In addition, when a individual sees the amount of money that his or her employer is paying for their health care coverage and compares it to what they can purchase on their own in a competitive health care exchange, that can also be a driver to more employee-driven choices in the insurance area. I do think there'll be a shift toward higher deductibles. That's already happening. The amount of coverage or the scope of coverage will also be limited to increase affordability. There'll be multiple plans that can be purchased by beneficiaries. All of this will put stress on providers. Insurance companies will come back to the providers to seek lower costs so that they can charge lower rates at the exchange and be more competitive. Again, this is kind of what I was getting at here. In the more competitive market, there will be more cost-conscious decision-making, pushing cost savings down to the provider level, and I think squeezing payment rates at that level in the private side. It also does ease the burden on the government to limit its costs, which it's obviously trying to do in this arena. And the other thing we'll see is antitrust enforcement increasing as markets start to shrink and these affordable care organizations kind of come up, and I think what we'll see is greater antitrust enforcement to kind of break up potential monopolies that are driving up costs. There are a number of specific elements in the ACO provisions that touch on antitrust provisions and kind of exceptions. I won't get into those, but it is going to be an increased focus area. Focus on chronic populations. Really, the disease management is really where kind of the rubber hits the road with respect to cost savings. And I think, Mr. Murray mentioned this quite a bit in his discussion with respect to the patient-centered home and other models of community-based care, where the idea is to work with patients with a chronic condition before they get to the acute status and make it to for a hospital admission. There is really going to be a shift, I think, in the patient homes or in the medical home concept to try to reduce those costs, particularly in the models of payment where you're getting a payment for a particular life. And you can treat that patient in a low-level setting rather than in the inpatient hospital setting. There are a number of demonstrations that are out there with respect to chronic care population over the years. I think CMS has had mixed results, and primarily it's driven by patient compliance as often being one of the critical elements as to whether or not a demonstration was successful or a failure. And I think that is something that needs to be addressed as these chronic care disease management programs continue to roll out through incentives for patients for making regular checkups, diet plans, that kind of thing. And I think we'll see more of that. And this is another area where the CMS Innovation Center is really targeting to try to find areas where they can reduce costs by addressing chronic care populations. Big Brother is watching, and this is really goes to the enforcement tools that the Affordable Care Act enhanced. Certainly there were a number of acts before the Affordable Care Act that provided substantial penalties, and both civil and criminal, for false claims or submitting false claims to the federal government in a Medicare or Medicaid payment context. What the Affordable Care Act does is it makes it easier for the government to share information between agencies. It gives the Department of Justice and the Office of Inspector General more direct access to claims data from CMS to mine that data to detect patterns and try to identify fraud and overpayments before they become substantial issues. There's this concept of real-time claims review using powerful software programs to predict patterns and detect risk areas before the provider has kind of cut out of town and left with the fruits of the fraud. But what happens in all of this, as you may know, is that while the targets are the bad actors, and there are a lot of bad actors out there, there are a number of innocent providers that get swept into the dragnet of these types of enforcement tools. We've had a number of providers that have relatively minor overpayment issues that become blown up into a False Claims Act type of situation, and you're put on the defensive. And when you're faced with the penalties that are provided in the False Claims Act, which are up to $11,000 per claim plus three times the damages of the underlying amount, you really don't have a whole lot of choice but to settle in some of those cases, particularly when you're dealing with a situation where you've got an error in kind of a billing program that has caused, or some kind of coding issue that has caused hundreds of claims to be overpaid. There was a mistake somewhere down the line that can suddenly have hundreds of thousands and millions of dollars of liability that's sitting out there. One thing of note really particular important note from the Affordable Care Act on the enforcement angle is that it also now requires, if it wasn't clear before, it is now under the Affordable Care Act provision, to report and refund overpayments within 60 days of their identification. So providers for Medicare and Medicaid services who have identified an overpayment, whether that be through normal compliance channel or hotline or whatever the case may be, have 60 days to report and refund that payment, or else it gets converted into a potential False Claims Act issue. And so what the Affordable Care Act does is, for providers who don't have really effective compliance programs and systems established, is it creates a risk that if you have overpayments in your shop that have not been identified but that could have been, that the Affordable Care Act can kind of convert those into False Claims Act issues, even though they may have just been mistakes or errors in your billing processes. So it's just another one of the enhanced enforcement tools that's out there from the federal government's perspective to recoup Medicare and Medicaid overpayments and kind of maintain the ongoing focus on only providing for the actual services provided. And while these are laudable goals, I do think there are a number of innocent providers that get caught up in the system. Will we rationalize the end-of-life care? There was a quote from a conference I was at a number of years ago, but I really liked it. It was, "America is the only nation where people believe that death is avoidable." And when you look at the amount of health care spending that we have in the United States, it's estimated that about a third of our health care costs are consumed in the last year of our life. For people with chronic conditions, it's the last 2 years of their life consume a great deal of the Medicare reimbursement that's paid out. In addition to that, there was a survey that was done that showed that I think 55% of people that wished to die at home in the survey actually ended up dying in the hospital in an ICU. It was up to 20% of those people died in a hospital ICU. And this all kind of varies by region, as Mr. Murray ended out. Where the hospital resources are, you do see a greater tendency in larger end-of-life costs. But I think this was an issue that came up in the Affordable Care Act, at least in the House bill, but that was really politicized a great deal, and kind of blew up into this whole death panel debate, and kind of took the discussion off track, in that really what the original House bill was trying to do was pay for services by physicians to have effectively counseling to patients to determine what their end-of-life wishes were. It was always patient-centered and patient-directed, but it was an opportunity for patients to express that to their physician and get that in the record, so that at the end of life, there was clear directive that only a small portion of the population really has, to kind of limit the amount of care to more palliative care, hospice-type care, rather than going kind of the full distance in maintaining life for those last few weeks. And having just dealt with that with my grandmother, who was 95 years old, broke her hip, and went through all of this, there is a tendency in the physician community not to want to throw in the towel, not to want to stop delivering care. So without that kind of directive, I think that there's a tendency for those costs to just rise based on that principle of wanting to constantly, do the best for the patient, make the patient survive, make the patient live, even if that's not always what the patient may want. If the patient hasn't expressed that desire, that's where we have this issue. But this is an area that I think has substantial costs in the healthcare delivery system. It's an area that but for political reasons, would be, I think, a target of more rational discussion with respect to palliative care, greater use of hospice at the end of life. And so we'll have to see how this progresses in the next wave. Bottom line is it's all about the money. And it really is. I mean, ultimately, when we talk about the delivery of health care in this country, it has historically been, and it will likely always be, driven by the manner in which services are reimbursed. When it was all cost-based system and you were paid based on how much services cost, the increase in costs of healthcare just rose and rose and rose because there was a direct relationship there. As the prospective payment systems gathered in, what happened was healthcare got fractured even more so than before, in that you would receive your hospital services in a hospital, be discharged to go to a rehab facility, get your rehab services in the rehab facility, go to the next level of care, and payment followed everywhere. An individual payment followed everywhere. Now, as we shift perhaps to a more bundled payment or outcomes-based payment methodology, there's the hope that this fractious healthcare system will try to congeal again into a more rational and connected delivery model, allowing providers to work together to reduce some of the duplicative costs that happen when you have such a fractious system. And it's going to be necessary. If something is unsustainable, it will stop. And looking at the straight line projections of healthcare costs as baby boomers grow up, the proportion of the tax revenue and GDP going to healthcare is not sustainable. It's something that has to be addressed. The Affordable Care Act was an attempt at addressing that, at least one attempt at addressing that, and trying to kind of bend the cost curve, move toward more outcomes-based, more healthy initiatives. And that's ultimately what's going to be necessary in order to maintain a sustainable model. But the current system obviously cannot continue going with the tax revenues that we currently have. So something has to give at a certain point, and we're getting closer and closer to that point. I think latest estimates were there's 15 years left on the Medicare Trust Fund based on kind of current expenditures. So it's a ticking clock, and we have a Congress that right now is not really prepared to deal with crisis situations. So it's going to be a very interesting, few coming years. And with that, I wanted to kind of open the floor to questions, to discussion, to kind of get a feel for your thoughts with respect to trends in delivery systems. Yes?
Okay, I hope you don't see the smoke wafting off the top of my head here, because you got my Irish up. The first three speakers were wonderful. We've got to create a culture of wellness. This system is unsustainable. This isn't a healthcare system. We need to create wellness. We need to include chiropractic care and our integrative healthcare practitioners, who are named in the Affordable Care Act as a national healthcare workforce. This system, we can't function in this. This is not about chiropractic. I'm a chiropractor. If you ask me to pay for episodes of care, I'm only going to get paid for that. I'm in the disease model. I mean, you get a sciatic flare-up, you get 8 visits, you're out, you can never have wellness treatment, you can never create a culture of wellness. How are we supposed to function in this system?
Well, I think the affordable care model provides substantial opportunities for chiropractic, in that when you have a system in which a bundled payment is provided rather than discrete payments along the lines, what happens is the recipient of that bundled payment has to determine what the most efficient and effective care models are for a particular patient, and funnel that patient through those systems. And that provides the opportunity that I think Mr. Murray was talking about, to kind of get into that model and be part of that system.
You will only be allowed to be paid for what is considered evidence-based on what works it doesn't work. Or the last 3 people are telling us this system doesn't work. Here's Business Week. But they're going to hold you to that standard. No, it can't be that. Nutritional services, you're not going to get paid for. Homeopathic remedies,
Right.
Herbal interventions, dietary, nutritional advice, you're going to be able to adjust L4-5, and that's it, for $20.
Right.
And, this is not good.
No, you're right about that, and that's one of kind of the, from a Medicare standpoint, but from private pay as well. I think if you're in that model, if you're the efficient provider, then from the private pay side, where there is reimbursement, you're going to see that increase vis-a-vis your peers if you're that efficient provider. Now, getting to your point of increasing the Medicare coverage from just neck and back, that's something that's that's a policy-driven angle that really has to be addressed with the CMS agency.
I'm not hopeful on that one, but do you think, your advice, do you think that if people speak up more, our community, a call to citizenship in our community of healthcare providers, if we do speak in the state insurance exchanges, for instance, if they are mandated to stay in, that to influence inclusion at the state level of these different types of practices and their products, do you think that would make a difference down the line in influencing this type of thinking?
Yes, I do. I think Medicare is very reactive when it comes to these type of things. And a lot of the issues that I have battled with Medicare on when it comes to kind of coverage issues have been, Medicare being behind the times of what really is effective treatment or effective care. And there may be a local, in a lot of the battles I've been in, it's been local medical decision or local coverage determinations that you're battling and trying to show that, look, what we're doing is it's medically necessary and it's got this evidence to prove it. Here's some studies, this and that. And Medicare reacts and they pay. The shift toward national coverage determinations is problematic, but there are fewer of those than there are, kind of local-based coverage models. And so I do think, yes, that impact at the state level, at the local level, where traditionally, the standards of care have been developed, is a good way to kind of have a grassroots effort to move toward greater coverage of a larger number of services.
Thank you. We'd have to have a little optimism for our students here.
Right. Well, it's a difficult time, but I think when there is the dramatic change in a system like this, that it creates opportunity as well. The number of home health providers before 1983 were minuscule, but after the prospective payment system came along, it created a whole development of a provider network that provided different services in the patient's home and became a model for shifting costs out of the hospital into the home. I think when you see payment systems have huge changes like this, it provides opportunities for certain service providers. And yes, there are uphill battles that you have to fight to overcome what has traditionally been done, but the best time to have that and make that change is when you're in a situation of radical change, which I think we're on the cusp of. So
Great.
If there's good news to be taken, it could be from that.
Wonderful. Thank you very much.
Hello.
Yes, hi.
Oh, there we go. I'm Dean DePais, a chiropractor as well. I guess I need clarification to help. I'm confused with the outcome-based agenda. So for instance, if we have a patient who's on blood pressure medicine and the blood pressure medicine stabilizes their numbers, in an outcome-based model, if that end is accomplished, that patient is considered cared for, and we haven't accomplished anything to help them be more healthy, and if anything, we've made them pharmaceutically dependent. Is the system addressing that, while the short-term outcome may be to stabilize a number, the process is more important than the outcome. Ultimately, we have to get them off of the meds or
Right.
Adult onset diabetes. If we get them on insulin and we stabilize their blood sugar, the outcome may be, okay, we've stabilized them, but no, the process is more important. And we've proven, what was it, like 93% of adult onset diabetics, if they change 4 primary behaviors of life, we could get rid of 93% of adult onset diabetics. So the outcome is not really the objective. We've got to work on the process. Am I missing something here?
No, well, a couple of things on that point. With respect to outcomes measured and payment for outcomes, keep in mind this is the shift. This is where things are shifting, but it's not there yet. And I think in the hospital context, when they talk about payment for outcomes, what's been measured is readmissions or deaths within a certain period of time after admission. That they don't want to pay for a patient to be admitted to the hospital and then pay for a patient to be readmitted to a hospital within X number of days. Now, when you shift to the physician, chiropractor, individual practitioner model, I think the outcomes they're not yet identified yet. I mean, there's still a process with there's the physician quality reporting model that's going on, and most of those are process based. But I don't think there's yet to be established kind of the outcome measure that's going to be a function of individual practitioner payment yet. But there may be, and I think as that process develops, that's when the dialogue with the state agencies, the local medical societies, kind of both medicine, chiropractic, various folks need to get together and determine what are we going to measure, what is going to be the outcome, and that's where the policymakers need to hear from the grassroots. But like I said, in the hospital context, that's really where it's mostly focused on what acquired condition, hospital acquired condition did this patient get? If none, then it was a successful discharge. Did they come back to the hospital within 30 days? That kind of thing. Payment for an episode of care, and positive outcomes being you didn't have X, Y, and Z.
Okay, so if I'm understanding, the work that's been done thus far in government is more to address what's happening with acute care, and
That's
we're
right.
looking for an outcomes-based improvement in acute care. Now, this would seem ironic, and maybe, but 3/4 of what we spend in America is on chronic care.
Right.
So once again, we're not even looking at the bigger sum of the money, and supposedly this is about the money.
Right. No, I agree. I think the focus on chronic care population is more at the patient medical home concept.
So how did
ACO.
somebody choose to focus on acute care first?
Well, that's traditionally how Medicare has focused on problems.
So the problem
have to go
is that entity of thinking
Sure.
is still at the forefront of leading these conversations. When will we get people like you leading the conversations?
Absolutely. I think that's the problem, is you have the Medicare program has started with hospital-based program back in 1965. And from that time, changes in the reimbursement methodologies have all been initiated at the hospital. It was focus on hospital. If you look at, the shift from cost to limits, then to prospective payment systems, it was all to the hospitals, and then it later followed with everybody else. I think that same mindset is in place, that we have to test these models first at the acute care level, these value-based purchasing models, these quality outcomes-based models.
I'm with you, and you're being very polite at how
Right.
you're saying it. My challenge is, I guess, is there any hope? Is there any hope that some leadership somewhere with enough authority would say, you guys don't get to speak on this conversation? We need vitalists here.
I think...
Is there any hope? From your perspective?
Yes, there's hope. There's hope. And again, I think it goes back to the point of, something that is unsustainable cannot continue. And the current model is unsustainable. And so what you have, obviously you have this inertia that you've got to overcome, but I think there is that ability to say, look, what we're trying to do is reduce the costs outside the hospital. We don't want to get to the hospital, so why should the hospital be the focus of the reimbursement changes in delivery system, let's make it be the community-based providers, because that's where we've got to start capturing the cost. I do think the Affordable Care Act takes steps in that direction. The medical home concept, the accountable care organization concept are kind of tend toward that direction. But this, you're moving a big
Right.
ship, the Titanic, and it takes
You're saying we have
time.
to be patient.
So yes, I think patience
Work on the process.
and persistence.
Right.
It's to show, and I think getting back to the term evidence-based, but to show that perhaps through working with the CMS Innovation Center, models that you can develop to show how you track particular patients and the effectiveness of community-based medicine in keeping those patients out of the hospital, particularly the chronic care population, which is a big population of interest for CMS and for everyone really. To show that there is an impact on the costs and the quality of care provided to those providers, I think earns you more stake at the table. And once you can start doing that, then I do think doors open. But you're right. I mean, you are fighting against just the traditional complex that's been out there, and it's going to take time. For example, I was mentioning the kind of rationalization of payment models for sites of service. Well, of course, it doesn't make any sense to pay 80% more for one location than another, but you've got a strong contingency of lobbyists and others that are going to fight to protect that, and so you have a number of factors going in, but there is hope. I think there is hope.
Thank you. That's great.
Thank you for your question.
It's a challenging exercise for a profession that's been marginalized historically from any cooperative ventures in addressing population health management outcomes, to now be given, in a sense, keys to a candy store where there's legislatively enabled participation and prohibitions against exclusion. But I'll submit that in many ways we as a profession don't know how to define our value in this new world order. And I think about the element of risk in all of this, because it seems to me that to define most effectively new population health outcomes and to collaborate in this new order, despite our suspicion, despite our mistrust of the environment that we're going into and having to work with other providers that have worked hard to exclude us,
right,
we're going to have to learn to carry some risk. And I don't think we as a profession really understand what that means. So I wonder just if you could offer some comments about the environment of carrying risk and how different providers in collaboration, especially who come from very different paradigms of health and wellness, controlling disease, how do we learn to collaborate when we have such different paradigms and view health and wellness in such different terms? How can we learn to carry risk in that environment?
Ooh, that's a very good question. With respect to the carrying of risk, I think that is one of the kind of difficult issues and problems with this shift to more accountable care organizations, patient homes, because you do take on the risks of particular patients being, you're going to have a fixed payment in particular patients being have far greater costs. That I think is difficult to handle as kind of an individual provider based and individual practitioner. And what will happen, I think, is that you may see greater consolidation of practitioners in order to help spread that risk. Now, with respect to the collaboration with other practitioners, medical practitioners and others, it's a good question with respect to how do you enter into an organization, and it may well be that the affordable care kind of concepts and bundled payment demonstrations are a way to kind of bridge that, where you can be at the table to be one of the providers in a mix that helps to develop clinical pathways for particular patients and diagnoses, and through that engage in dialogue with that community, as you said, you've kind of been excluded from in the past, but I think it's an opportunity to at least start that conversation. In that may be more difficult than the whole risk issue when it comes to that. But I think you can also control risk by trying to tie in and be a part of that particular organization so that the risk of higher costs are spread amongst not just the chiropractic, but all the providers in that particular network. So those are some ways of addressing risk, but it's a complicated issue for sure.